recorded.
This conference will now be recorded.
Okay, my name is Peter Kafka. I'm usually in my home in Maui doing this, but this evening and for the next 4 or 5 months, I will be in Minneapolis, in the Twin Cities. So it's good to be back here. I've been doing this for about 5 years, going back and forth. So let me mention our sponsors first, which we're very happy to have. We are not beholden to them. We are not promoting their drugs, their products, their tests or whatever, but they have seen the value of our peer support organization, and they have been very generous in supporting us so that we can continue to work and put on these meetings and our webinars and other activities. We are a volunteer organization. All our moderators are not paid at this point, and we just do this for the love of it and the passion of it, including our founder, Rick Davis. So we are here week in, week out, whether rain, shine, holidays, snow, we are always here. I don't think we've ever missed a meeting for anything but technical difficulties, and even those are very few and far between over the years. So our sponsors are Bayer and Pfizer and Janssen, which is part of Johnson & Johnson Pharmaceuticals, and Myovant, Myriad, which is a genetic testing business, and Telix, which is a scan-based sponsor. So we're very thankful for them and their support over the years, over the past year or two. So we're going to get going. Is there anybody I haven't reached that came in the last couple of minutes? I don't think so. David Muslin, yeah, you're gonna be up because we missed you last week, and I know you probably have something to share. So we have one new person, and it's Jay, and he's in the Villages down in Florida. But he asked not to go first. He wants to see how we kind of run, but we don't have another new person. So you will see how we run just by some of the other guys as they talk, and then toward the middle of the meeting, I'll get to you, Jay, and we'll ask you some questions and get you up to speed in this. Okay? So
Great.
Relax. This is not there's no hot seat involved here. This is a pretty relaxed group, even though there's over 30 of us, and we get into some pretty detailed and complex stuff during these meetings, particularly in this one, which is the advanced group. And some of us have been working with this disease for years, and we kind of put our brains and our hearts into this and compare our knowledge and try to help each other the best we can. We're not medical doctors, although there are a few medical doctors on the call, but we don't provide medical advice. We just provide peer support and help guide each other the best we can through our experience. Okay, so with that said, there's a couple who have short things. Let's start with them. Frank, do you want to start off quickly?
Sure. I mentioned last week that it doesn't pertain to my prostate cancer, but my diabetes pharmacist changed me over to Metformin, and I started that this past week and has successfully transferred over to it. Had minor stomach issues, but they seem to have settled up and not any big problem with it. Also, you may see some lights going off behind me and some flashes. I had my pacemaker changed out this week. Got a new Timex, and it's ticking very nicely. actually a Medtronic device. So I went through that. Everything was successful, and I'm good for another 10 years.
Very good.
Yeah.
Very
So
good.
that's my good news of the night.
Okay. So just as a quick follow-up, Rick sent me a study was done by a professor recently about uh, possible effects of metformin with the immunotherapy drug Keytruda. This doesn't apply to probably many of you or any of you, but it did apply to me. And later on, when I get to talk about my situation, I had to talk about this with my medical oncologist here in Minneapolis about the effect of metformin with the drug Keytruda, which is an immunotherapy drug. And and he had some interesting comments about it. So I won't belabor it, but for the most part, metformin, I took it for years, and there's no empirical evidence that it's great for fighting cancer. But I mean, I did not take it for a diabetic condition. I took it because I heard it was a good cancer fighting drug, and it's inexpensive and easy to get. But it might have some downsides, particularly with immunotherapy drugs. Anyway, let's move on here.
Anybody I'm just curious, how many people in this group, you can either raise your hand or use the react, which allows you at the bottom, that allows you to put a hand. How many people are on metformin in this group? So I see 4 people with hands raised. Anyone who hasn't raised their hands, just wave in the screen. So four of you. Okay. And is that all? Are you all taking it because you think it helps with your prostate cancer? Or I've got 5. I'm going to put the hands down now. And if you're taking it for prostate cancer, please click again. Let's just see how many people are taking it just for prostate cancer. So everybody who raised their hands is taking it for diabetes. Interesting. Okay. I mean,
But Rick,
there was a time in the days of Snuffy Myers where it was very popular to take what was it called, SAM, statin, aspirin, and metformin, no matter what. Statin, aspirin, and metformin. And we have been the Brains Trust, of which I am privy to see that. I don't consider myself to be part of the Brains Trust, but I do see their correspondence, has been talking about the role of statins in controlling testosterone. Controlling is the wrong word, but the roles of statin as it pertains to testosterone, because it's more complicated than most people would think. The cancer has an ability to decompose the cholesterol in your body and to grab the testosterone that helps make up that cholesterol, because the cholesterol is the root of the cholesterol is a testosterone compound. And so, when I think the background to statins is probably just lowering your testosterone, and they do this. From what I understand, Ben's the one who's going to correct me here, but from what I understand, the cancer gets at the low density better than it gets at the high density, and the statins tend to help with that. So that's just a side effect, because we don't have a lot of people in here today. Go ahead. unless there's any questions.
Okay. Mike Yancey, you said you had a quick thank you.
Yeah, I just want to thank everybody. Last week I was kind of sharing with you everything that's throwing at me right now, and also the fact that I'm just started radium 223, and so it was kind of brought up that was I taking Xgeva, and of course at that point I was not, and so I talked to my rad onc, and he said there's really nothing he was doing with radium that I needed it, but talked to my med onc, and of course my med onc had tried to push it on me before, and I'd kind of pushed back because my bone density was looking good, but anyway, I talked to my med onc, and he said because I've been on ADT so long, I really should start taking it. So Friday I'm getting my first dose, so just want to thank everybody for watching out for me.
Okay.
Pleasure. It's a pleasure. You got a hand up. You got a hand
Steve,
up, Peter.
Did you have a comment about the what Rick was talking about or something?
Yes, I do. As a matter of fact, I was wondering how
ahead.
dated. I have a question about what Rick had mentioned about the statins. You know, I had high cholesterol before my diagnosis with my prostate cancer, and I did run across an article, some obscure thing I picked up off the internet from a study group out of the UK involving statins, but that was not what the study group was looking at. They were not looking at a correlation with prostate cancer, but there was some comments made in that paper about how they thought that would impact, you know, improving the odds of the cancer not recurring. And I'm just curious, Rick, how dated was that information that you saw? What I read was over a year old.
Well, there's two things going on here. There's a lot of stuff in PubMed, I think, on the role of statins and prostate cancer, because there were many studies done probably 10 years ago. And again, I got to defer to Ben and to Len. Len isn't on today. Len knows quite a bit about this. Unfortunately,
Len will be on in about half an hour. He's stuck in traffic.
Oh, okay. So, you know, if we got time, we'll come back to Len and ask him. The stuff that we're talking about is very recent stuff.
Okay.
It's there's a suggestion that the cancer is so clever that it can actually make cholesterol. So not only can it get to the heart of the cholesterol and pull out the testosterone, but it's figured out how to make more of that food overall. And this is way, way above my pay grade. And this is something very recent. But the question as to the age of the stuff on statins, I think if you go to PubMed and just put in statins and prostate cancer, you'll come up with a slew of articles. I'll take a look in a second. Herb, you wanted to say something about that?
Yeah, that kind of ties in with something that my med onc mentioned the last time I had an appointment with him. And he said that there was some indication that prostate cancers can figure out how to make their own testosterone.
Right. So that theory has been around forever. Back in 2008, I remember listening to Chuck Ryan talking to us about abiraterone. And abiraterone at that time was still in trial. I don't even think it was in phase 3 yet. I think it was in phase 2. And him telling us that the cancer's so smart, it can get to its own it can make its own testosterone. And we said, well, somebody, you know, how? And he told us about how it decomposes the cholesterol and it pulls the testosterone out of the cholesterol, and that the mechanism of abiraterone prevents that. But this new study that we're talking about right now seems to say that not only can it pull it out of the cholesterol, it can just make more cholesterol overall, create more cholesterol. So I don't know. Ben, you turned your camera off. Do you want to say anything about this? He's left me
Yeah,
holding the
let's
baby
wait till
here.
Len. Let's wait till Len comes in a little bit later and maybe bring this up if there's time. How's that?
Right, and we'll get back to you, Steve. We'll direct you to some references. This is a perfect, you see, this is a perfect opportunity for the forum. You can put something in the forum and then people will respond to it afterwards in writing. Go ahead, Peter, sorry.
Okay, David Muslin, you didn't have time last week, and I know you've got some challenges going on. Do you want to update us? What's happening?
Okay, are we back? Can you guys hear me?
Yes.
So I've got two things to talk about. One is fatigue, and the second one is if anybody was familiar with this new drug that was approved last Friday for hot flashes by the FDA. I'll go with my hot flashes first. So I've been on, a couple things are going on, but I've been on darolutamide for a year and 2 months. And about a month ago, I started just getting some extreme fatigue about 2 to 3 hours after I take the drug. And, so I'm not sure if it's the drug or I'm not sure if, I get up in the night probably 2 or 3 times a night. I'm not sure if I'm just tired, but I really think it's the darolutamide. So, and I just wanted to get some feedback on that and see if anybody else has been. I know Len stopped it after a while because he was getting fatigued, and I just wanted to check that out with everybody. That's number one. I'll wait for a response there.
Well,
Yeah.
I was on darolutamide, and it fatigued the hell out of me.
I'm on 600 BID and I'm exhausted, very fatigued.
I had the problem with it. I had the problem of fatigue with enzalutamide, and since I've switched to darolutamide, I haven't had any fatigue. Go figure.
They had me.
I did fine on darolutamide. I was on for almost 2 years, but at a certain point, I hit the fatigue thing. And I talked to Len and I talked to my doc, and what I did was I cut it in half. I'm not telling you to do this. I'm just telling you what I did. I cut it in half, and that worked for a while. And then when I started immunotherapy, it just didn't go with it at all. There were no studies saying how the interaction was, but I knew that I was having a terrible reaction with it, so I just stopped it altogether and let my doc know, and I've been okay since then. But yeah, it can affect you. And I was speaking just a couple of days ago to to Dr. Name slipping my mind, down in Tucson. Whatever his name is, the ER doctor.
Carlos.
Carlos, yeah. He's having some big problems with darolutamide right now too, with fatigue, extreme fatigue. So it happens.
Yeah, and it's usually after some time, correct? A year and a quarter, whatever, 2 years.
Seemed to be with me. Yeah, it seems to happen.
Yep. So I think I'll check in with. I'm going to check in with Len at another time, and then and thank you for that. And I'm going to call I'll call Russell Schmulowitz and see what he says about that. And anything else on the darolutamide front, guys?
Yeah, well, you can talk about cutting it in half. Instead of 4 pills, try 2, and see what the doc says about that.
Yep, we'll do.
Still suppress your PSA, Peter? At a half dose?
Oh yeah, look for that. It did that. It did the job.
Yeah.
When you cut it in half, your PSA stayed undetectable?
Yeah, it still worked.
Yeah, I mean, I've been undetectable and a little reluctant to drop it down, but I think the fatigue is starting to wear on me on a daily basis.
Oh, hi, it's Larry Fish on the phone. Can you hear me?
Yes.
Very interesting, because I've been talking to my doc about taking a drug holiday, and I'm on Lupron and darolutamide, and she keeps saying, well, drug holiday, she suggests taking the holiday from darolutamide, and I'm thinking I want the holiday from Lupron. And now it sounds like I haven't hit that fatigue yet. So Anybody thought about, like, on Lupron and darolutamide, stop the darolutamide as a holiday?
Just to be clear, I'm on monotherapy with just
Mono.
all I'm on is
Yeah.
darolutamide.
Right,
Larry,
that's what I wanted to do. And she was saying, well, why not just go back to monotherapy, Lupron, which didn't work. I mean, at one point, that was strange to me.
Well, I'm currently going through Lupron injections and biculamide, and biculamide was only through the end of March, and then they stopped prescribing that to me. I was part of a clinical trial, but my fatigue seems to be coming from the Lupron, not the biculamide that I was taking earlier this year.
That's a little different, Steve. The bicalutamide is given before you start the Lupron as a buffer because of the way that it's really just because of the way the Lupron works. And with some of the drugs, you don't need it, like with Firmagon or Orgovix. So it wasn't given to you as a long-term protocol. The fatigue that you're feeling a little bit is pretty typical when you take an LHRH drug. The guys who are on doublet therapies sort of get it two ways. And that's one of the reasons why we say to them, well, try a monotherapy. Try just the second line anti-androgen, whether it's darolutamide, enzalutamide, abiraterone, and drop the LHRH. But that is not, it doesn't have the clinical evidence. There's a lot of anecdotal evidence. I mean, here we've got somebody who's been on monotherapy, Abby. We got two or three guys being on monotherapy, darolutamide, monotherapy, enzalutamide, apalutamide. But the doctors are not willing to do it unless they're pretty forward thinking, because they don't see the evidence for that. We seem to think anecdotally that it's a way to go and it's a more effective way to control the cancer, but that's totally anecdotal. And by the way, I put a link in the chat window for you for statins and prostate cancer with 656 results, so you can tell us what you find.
Thank you. Yeah, I saw that. Thank you.
David, tell us about this new hot flash drug.
I'd love to drop my Ember, and I read it, and my wife actually sent it to me on Friday. FDA approved a new drug. I'll spell it FEZOLINETANT, and they're going to use the name Veozah, VEOZAH, is supposedly a new drug for hot flashes for women going through menopause. And just curious if anybody has seen it or talked to their docs about it or tried it.
I saw it was coming out and it was being pushed just for women, but I do not know.
All right, I'll put it in the chat window so everybody can be familiar with the names. And when I check in with Russell this week, I'll ask him about that as well and report back to the group.
David, I saw a drug was approved, but I didn't think it was last Friday. So I'm just wondering if this could possibly be the second one. I think I bookmarked the first one. Let me just see.
I'll send it to you.
Yeah, okay. If I figure out what I read, I'll let you know.
Very good. Thanks so much, guys.
Okay. Is the Ember Wave not working for you, David?
During the day or at night when the hot flash comes on, I hit it, works perfectly. I mean, it really drops it quickly. But at nighttime, it doesn't help me that much. And I put it in the nighttime mode, Peter, but it just wakes me up, and it's just fucking terrible at night. And that's why I'm up. That's why I'm up so much at night. And I thought that could be adding to my fatigue as well. but the night mode doesn't work that well for me.
Interesting. Jeff, you're the Ember expert. Do you notice a difference between night and day activity with the Ember?
Well, it varies. It depends on how intense your flashes are at any one time. I know for me, usually overnight, it will really suppress almost everything. But once in a while, I'll have one. It's during the day. I don't know if it's as much suppressing them as it is when you get one that you stop it from getting stronger. Whereas at night, you're trying to suppress them.
David, is my mic working?
Your mic is working, John. Go
Yes.
ahead.
This fezolinetant is, like you said, it's only indicated for hot flashes due to menopause. But looking through the information, it doesn't look like there's any reason why men can't try it off-label. I could take a look and see if anybody's done any study that included male subjects, but it doesn't look like it from my first glance at it. I also wanted to mention that I was listening to a complimentary doc giving a talk a few days ago, and he mentioned a fungus called cordyceps for fatigue that he sometimes uses in his patients. The evidence is not there for, in terms of any kind of double-blind study, but there's some evidence it might be worth trying for a couple of weeks and see if it makes any difference. I get the same thing. I'm even off my Daro now, and the fatigue is just killing me. But cordyceps.
Oh, guys, there was another medicine. Oh, no, it's the same one. Veoza. That's the one we're talking about, right, David?
Correct.
Yeah.
When you guys have fatigue, is it all day fatigue? Because I get fatigue, and if I lay down for maybe an hour or two, then I seem to be a little bit better.
Same. But I can pretty much feel it, like in 2 hours or an hour and a half after I take the drug.
I just have it all the time. I could go to sleep anytime, day or night. And even now I'm sleeping about 12 hours in any 24.
And what drugs are you on, Dr. John?
I was on Daro last, and that stopped last August, but I still have 0 testosterone.
Got it. So you've been off Daro for a year.
Almost.
And your PSA is staying undetectable, and you're okay. So you've been
Yes.
on a real holiday.
Yes.
And you still have fatigue now?
Yes.
Did you say you're on darolutamide alone and your testosterone is 0?
Yes. But I'm actually even off the darolutamide now.
Wow.
Did you have COVID? Could it be a COVID, long-term COVID?
I never did that I know of. Anybody
That's
else?
just one of the symptoms some people get.
Interesting question, huh? That we should all raise.
Right.
I've been on a drug holiday for a year, not taking any drugs, and my PSA is undetectable. My testosterone's up at 350, and I still get fatigue.
Oh, jeez. Go figure.
Yeah,
Huh?
I mean, some of these regimens we've been on, have a cumulative effect and can, I don't know if there's any going back. That's been my experience. I mean, it doesn't necessarily mean extreme fatigue for the rest of our life, but we're not going to turn into 25-year-olds again. That's for sure.
Except
Excuse
for
me, Peter.
Jimmy.
No
I was
more
going to
operator
say, except for
battery.
Jimmy. Yeah.
Well, and my fatigue totally went away the minute I stopped enzalutamide, and I'm now on darolutamide with no fatigue. Again, go
Great.
figure.
We've seen that before when people have switched. Well, David Muslin's a great example. Switching from ends to Darrow and things changing, but then the fatigue caught up with him. Jim Marshall, go ahead.
Let's see a question. Anybody on the hypertension drugs okay at the same time? Because of the fact I have noticed I'm on a holiday for about 9 months now, and when I get fatigued, especially afternoon wise, and so I got suspicious, and and I had a blood pressure of 90/50. So I think it was due to the drugs I was taking during the time I was on the Lupron Abbey, and I got off of it, and so I have now had to back off, okay, of the hypertension drugs. So
Interesting.
So I'll share with you one thing that was left with me after doing 2.5 years on an LHRH. It totally changed my sleeping habits. I mean, I was somebody who before I had was diagnosed, I could get by on 6-7 hours. I never ever slept 8 hours. And as a result of being on the LHRH now, I can sleep 8 to 10, 8 to 11 hours without any trouble. I mean, it just completely changed my sleeping habits. I need way more sleep now than I did before. And I have to think it's related. And usually the older you get, the harder it is to sleep. Not for me. That LHRH took care of that.
Right.
Do you
Not
use a
for
sleep
me.
tracker? Do you use a sleep tracker to find out if your deep sleep and light sleep is?
No, I don't.
That's what I was
I
wondering,
don't.
if it was true deep sleep or you're just too exhausted to get out of bed.
No, I mean, I don't go to bed exhausted, but I go to sleep very quickly when I go to bed. I don't read in bed. I just turn off the lights. I'm usually asleep within 5 to 10 minutes. Once in a blue moon, that doesn't happen, but that's usually what happens. And I'll oftentimes wake up after about 2 hours or 3 hours, and then I go back to sleep again, and I get back to sleep in 5 minutes. But I don't know how deep the sleep is. But that whole pattern has changed completely.
Interesting.
Something to look forward to.
Okay, Jack, we didn't get to you last week either, so
Okay, it's been a while. Let me give you, I've been through, I've had my SBRT, pretty intensive 5 days of it, to the 3 lymph nodes in my lungs, to the L4 vertebrae and the left posterior lateral rib. It was quite an experience, but I'm glad it's over. Side effects bother me. The major one that bothers me that I think is related to the SBRT is my blood, the bone marrow. My white count really went down to 2,000. Somewhat anemic. I usually run a high hemoglobin hematocrit. This is pretty low for me, 13.3 rather than 15.6, 16. And my platelets went down from about 200 to 130. So that's going to take a while. I don't know if it's SBRT or whether it's the darolutamide 600 BID I've been on for 2.5 months. Gablosa seems to believe it's the darolutamide. He says it will come back. I don't know how long it'll take to come back. Maybe you can give me some feedback in your experience, how long it takes to come back, and that may be contributing to my fatigue, which I'm feeling quite a bit. And I've only been on darolutamide by itself for 2.5 months, and I feel very, very exhausted. The other symptoms I have a sort of a cough and difficulty swallowing since the esophagus and the bronchi was so close to where they did the radiation, and that's quite painful. I take a lot of Tums, which I haven't done in the past. I feel like I've got like an ulcer or gastritis, and I'm coughing more than I usually do, and so that's been a problem. Hopefully that'll go away. And I've asked why I don't have, like you, David, have mentioned, breast tenderness, and if that takes longer. And he said to me, you probably won't get that because you're so thin. He said, you mean there's an advantage to being thin? He says, yes, because estrogen accumulates in fat cells, and the more fat cells you have, the more inclined you are to get breast gynecomastia and breast pain. Well, I have a little bit of breast tissue I hadn't noticed before. It just text, but he said, well, as long as you don't get pain, there's no reason to be concerned about it right now. So, and I'm not having hot flashes yet. So he said that's a function of your being thin. So I don't know if a remedy is to hot flashes may be getting as thin as you can possibly get. Maybe it is. I'm not sure, but that's what I was told. So the white count, I wanted to know whether or not, how long it has taken you guys to recover. My PSA is undetectable with darolutamide by itself, several times 0.014, which is lower than Sloan Kettering. They wouldn't even consider that detectable. And my testosterone is 728, floating around there uselessly, and I'm hopefully not being converted to dihydrotestosterone and estrogen. So I'm about to start Orgovix. It's being delivered tomorrow, expensive drug. Do you all use Onco 360 as your delivery pharmacist? They called me for the first time yesterday, and they coach you and they talk to you. Onco 360, is that familiar?
Yes, I've used them, and I think they're excellent. They have a pharmacist available 24/7. They call you to let you know that your drugs are ready to be sent. They send them. Or at least mine sent FedEx, and I have to sign off on them. But I have high praises for Onco 360. Everyone I spoke with, fantastic.
That's good to know. So that's going to happen tomorrow, and I'm not looking forward to starting. But the way they want me to start, they want me to reduce the the darolutamide by 300 BID rather than 600, and he wants me to then introduce Orgovix, just one tablet without a loading dose. I don't have to take three because I've been on the darolutamide for 2.5 months. My testosterone, my PSA is down to 0. So I'm going to be starting that. I'm a little frightened of doing that because of what I've heard in terms of all the side effects, but I'm going to do it. And then a month from now, I'm going to monthly EKGs because of my particular tendency to be have an arrhythmia. I just had an ablation. I didn't need it, but I had it. They went in there to decide that the old ablation was still working, so they just adjusted my medication so I don't take the Multac anymore. So it's not relatively contraindicated for me to take Relugolix and darolutamide. So I'm doing that with metoprolol and one other drug, diltiazem, and Lipitor, and I was under the impression that cholesterol was the precursor of testosterone and estrogen, but this whole thing you were discussing before about coming from cancer cells, that's totally new to me. So that's kind of where I am. Any feedback? Anything you can give me about the bone marrow suppression and how long it takes to recover, and now that I'm starting doublet, what should I expect in contrast to what I'm feeling right now, which is the fatigue and muscle atrophy and weakness. I walked about 4 or 5 miles today. It wasn't easy, but it was at least on the beach and it was cool. And
pretty good. 4 or 5 miles is pretty darn good.
Yeah,
Is
it's not
is
easy.
is the 5 sessions of SBRT the only radiation you've ever done, or do you
In
have a
my life.
longer set?
No, they were 2.5 hour sessions each, and they did, whatever, 5 fractions of each area, and it was quite,
What have
quite
you
a.
had? What have you had other radiation in the past and so forth?
Never. I had a prostatectomy almost 21 years ago, and I've had no subsequent treatment of it at all until now, and
Okay,
only
because
my biochemical reoccurrance that started
right,
me
because
back on treatment.
I've done a fair bit of radiation. I've had red blood cell bone marrow suppression, for, early on, and Dr. Schultz in LA, he feels, and when I've asked him, he feels it was pretty much the radiation that's suppressed my bone marrow, the ability. I don't have problems with the white, but I certainly have problems with red. Uh, it's just not coming back 8 years later. I've never been able to get out of an anemic situation. My
Really?
hematocrit, my
What
hemoglobin, everything's low.
what are they? What's your hematocrit and hemoglobin?
Hematocrit's around 28, hemoglobin's around 9 to 9.5 every month. So it just never comes up.
Oh, do you feel weak or out of breath or anything?
I don't have reserves. No, I don't feel out of breath, but if I tried to walk 5 miles, I would feel it. I mean, I can do it, but I'm exhausted and I don't have reserves. I don't have anything to back me up.
It's interesting. So my white count more than my red count was affected. You know,
Interesting.
and a lot of immature cells are showing up on my smear on the white count. So the bone
Well,
marrow is trying to do some work.
well, hopefully it'll come back.
Yeah,
Hopefully it'll come
hopefully.
back. Give it some time.
Yeah. How
Okay.
about hormones? Do the hormones cause the suppression of your? Have you noticed that of your bone marrow? Anybody? Hormone deprivation?
Yeah,
Yes,
I think all of us with ADT got mild anemia.
yes, but it takes time. And I think that it's probably going to be more related to the LHRH drugs than it is to the second line anti-androgens, except maybe abiraterone. But yes, I mean, most of us who did it and have done it after several months start to see some impact.
So the white count also went down with the hormone deprivation, LHRH.
I don't
I
think
think
so.
I think it depressed everything, but I'm not. For me, I can't remember. Maybe Dr. John.
Not for me. No, no, just red cells.
Just read. Okay, I can't remember, to be
Yeah,
honest,
there's a lot
Doctor.
of things that affect white, including a small infection, and I mean white can go all over the place.
Yeah, I know. I just, with all the
Yeah.
bugs around, I don't want to have to isolate myself that much and put on masks more than usual. But
Right.
okay, thank you.
Okay. Good. Jay, you feel ready now? We're at the halfway point.
Sure.
Okay. Well,
Um,
I'll start. I'm going to start by asking you some questions, and
sure.
that'll fill things in. So, you live down in the villages in Florida. How
For
old are you,
7
Jay?
months. I live in Rhode Island for 5 months, and the village is Florida for 7.
Okay. Similar to me, but I'm the reverse. Um, how old are you?
75.
Okay. And tell us a little bit. When were you first diagnosed? Um,
I was first diagnosed in 2020.
okay.
Received external beam radiation and Lupron injections. I think I had like 2 Lupron injections
Hold on.
before they.
Jay, hold on. Let Peter lead you
Okay,
because we have other questions. Go ahead, Peter.
So
sure.
when you were diagnosed, what did they find? What
They,
Gleason grade did they give you?
7, 4 plus 3.
4+3. So they told you it was high intermediate, and you
Correct.
needed some kind of treatment.
Yes.
And you had where were you treated?
In Florida, Advent Cancer Center in Chavares.
Okay. And was it successful after your initial radiation? Did PSA go down? And
Yes, it was undetectable until 2022, the end of 2022.
okay, and what happened at that point?
It started to increase to, I think, 1.6 and then 2.4 within a matter of a few months.
Okay, and who are you currently seeing? Who's your doctor now?
I was seeing Dr. Jane in Florida, um, and he got transferred to Orlando, and seeing Dr. Corrode, who is his replacement.
And is he a medical oncologist?
Yes,
Okay,
I
and
know
does he?
he's a radiation oncologist.
Okay, and do you have a medical oncologist at all?
Yes, I do.
It's
Dr. Sampavde.
okay, and is he specialized in prostate
G
cancer?
Yes, GU medical oncologist.
Okay, and all these doctors are at Advent still?
Yes.
Okay. And what are they proposing, or what are you thinking about at this point?
I've already gone through radiation. They initially gave me Degarelix injections and Xtandi.
Okay.
And then maybe a month and a half or 2 months, then I had 30 treatments of external beam radiation.
This is you mean recently?
Yes,
Or
in 2023. Because
what kind of radiation did you have in 2020?
same thing, external beam radiation to the prostate
Okay,
and
but now
surrounding.
they're radiating someplace else?
Yes, it metastasized to the lymph nodes of the pelvis.
Wow.
Lucky me.
Okay, so it's not in bone yet, it's still in lymph nodes. Is that what you're
Correct.
saying?
Yes.
Okay. That's a lot of radiation in that area. It's amazing. So amazing that they didn't, I guess they only radiated the prostate and not the pelvic girdle when you did it in 2020, is what I'm picking up.
Right. That's what I believe that's correct.
Okay.
They in 2020 it was just the prostate and surrounding area, but not the whole pelvic girdle.
And did they give you any did they give just one second. Tisha, this is not the MS call yet. The MS call will start at 8:30 Eastern. So if
Thank
you're
you
here,
so much. Y'all have a blessed
okay,
day.
come right back here at 8:30 Eastern or whatever time zone you're in, okay?
Will do. Thank you so much. Y'all be blessed.
Bye. Sorry. Did they give you any? Did they give you any LHRH drug, Lupron, or anything when you did the original radiation?
They initially gave me Lupron injections.
For how long?
I believe 3 months.
Okay. Okay.
Okay. So, so are you in the midst of this radiation, or are you finished with it now? This
I,
last
I
session,
finished with it.
and how are you doing? With
Shitty.
yeah, I can imagine.
Um, but I think it's more the drugs than the radiation.
Okay.
Because I was feeling pretty good until the Degarelix injection. And with that, I had a whole bunch of symptoms. And then adding the Xtandi, I think, exacerbated it.
Did you only get one at the Garrelix?
4.
Four.
They're
Yeah.
monthly.
Okay. And
And
okay.
they're going to switch me to Lupron for my next injection.
Okay. Yeah. Are you happy with your doctors there? I mean, do you feel like you're getting the best care you can possibly get?
I do, because I went to Moffitt to get a second opinion, and they agreed that the treatment that they offered would be the same.
Okay.
It just the drugs are really knocking me for a loop.
Yeah, they can, and they have all of us.
Right.
Right. But you've had a lot of radiation too, which is which is, I don't know, a flag goes up in my mind for that.
Well,
Yeah.
Peter,
So and you're on Xtandi
Peter,
too. Go ahead.
Peter, I just want to say, not really, because if they treat the prostate bed initially, 30 fractions, it's usually 25 to 30 fractions. And if they, but then they'll add another 20 odd fractions if they go to the pelvic girdle. So it's not probably in total that much more than, say, somebody who got pelvic girdle plus the gland. I mean, the questions are, why didn't they just do SBRT to begin with? They could have done in 30, they could have done it in 5. But a lot of these community hospitals, they don't have the equipment, so they don't offer it. And if I said to you, well, he had 5 SBRTs, plus now he's doing 30 IMRTs, that wouldn't amaze you so much. So I just want to put that into perspective. What the couple of things that I wanted to raise, Jay.
Yes.
The first is, have they done any sort of genetic testing on you?
No, but I just signed up for color genetic testing.
Right. And
And
for free?
yes.
Good. Yeah. Okay. So that's the PROMISE study. And do you have any cancer in your family?
No.
Okay. The other area that we think we recommend very strongly is to do what's called somatic testing, which is to test the tumor. In your case, it's going to be difficult to do that now that you're on the drugs, unless you have a lymph node that can be biopsied. How did you figure out where your lymph nodes were? Did you do a PSMA scan?
Yes. I did a PSMA in January of this year. And that's how they discovered that it was in 2 lymph nodes on either side, and only like 1 spot in the lymph node on each side. Also mentioned, I asked the doctor about doing all of the radiation to the same area, and he said that he's not doing it to the same area. When he was doing it to the prostate, that was lower, and now he's raised it up and doing it to
Right.
the pelvic area.
Right. He should
Just
be
like
going,
thought.
hopefully he's going right across the pelvic area, although sometimes they do what's called this rabbit ear pattern, which is like two rabbit ears on either side, but he should be going right across. I don't say he should be going. If it was me, that's what I would be getting, right the way across. That's what, when we talk about pelvic girdle, we talk about it right the way across. The bigger issue, I think, that everybody might have something to say about on here that may help you feel better if you are not already doing it is how much exercise are you doing right now?
Um, not much at all. I have a dog, and we take the dog for a walk,
Okay.
so that's not really.
So let's throw this open because it's always a good conversation and address these crummy side effects you're feeling from taking these drugs. And who wants to kick off the conversation to explain how a little bit of exercise helped them when they were on those same drugs? I see Jim Marshall's already got his hand up.
Yes, anyway, I started and with Lupron, okay, abiraterone, and I was also we're exercising. It's on a bicycle, not hard, but just every other day. And so for the first 3 months, the only thing I knew I had was then anyway hot flashes. So I found out that provided I did not exercise, then I would get tired. Now, provided I happen to slack off, okay, and I got tired, okay, and I wanted to go to the couch and just sleep, I had to drag my butt outside, and it was a chore to then force myself to then get onto the bike, start to pedal, and go slow. And by about 3 blocks, I was recovering. So, as I said, aerobic exercise I found is just absolutely amazing.
Yeah, you've got to push yourself, though, and it's a good thing you got to have that motivation. Peter Goodell.
I just want to. I'm currently on a 3-month Lupron shot and enzalutamide, and I go to LA Fitness usually 5 days a week, and there are some days I get up in the morning, I'll have breakfast, and the only thing I really feel like doing is going right back to sleep. But instead, I grab my gym bag, and even if it's not a great workout, I get my butt there and you work. I ride the bike, I lift weights, I go to classes. They have strength classes. I go to a dance class, I go to yoga, pretty much 5 days a week. And on the weekends, I usually walk because I don't want to go there on weekends because it's too crowded. But I can't emphasize how little fatigue I have, how little hot flashes I have. I mean, if I drink a cup of hot coffee, I get a little warm. That's about it. And I attribute it all to exercise. And so I'm a big, as you can hear, I'm a big opponent of exercising if you can do it. Get out there. It's great for the mind. It's great for the body. So that's my plug for exercise.
Very, very good. And getting out, not doing it in your own home, but driving, whatever it is, 4 or 5 miles, 10 miles. Once you're at a gym, there's no excuse. You're not going to turn around and go back. You're going to follow through.
And it's also being with other people.
Yes.
You're on the treadmill running next to some other guy. I shouldn't say that. When I'm on the treadmill, I never run, ever. I'll walk a little fast. I do the elliptical. I never keep up with the next guy. I don't care. I'm there, and I usually leave sweaty. And when my shirt is totally soaked, I know I did a good job. then I get to go home.
I got a totally soaked shirt and I'm just sitting here.
That's
Yeah,
good.
it's
Steve,
good
you had a
advice.
comment.
I just wanted to say that exercise made a huge difference for me. My diagnosis, it came late last year into the fall, and they didn't really get started with any kind of EBRTs, the radiation. I had high dose radiation surgery as well, uh, and then I'm on the Lupron as well every 3 months. And all I can tell you is living up in northern Michigan, I got to pick and choose the days I can go outside for a walk, and I couldn't do that in the fall and in the winter. We tried to go to a gym here nearby, an exercise facility, and I tried to use that program. But I'm going to tell you now, what made a huge difference for me was getting on the bicycle. And I think what Peter was saying, or whoever was saying a minute ago, about having somebody there with them, to not to compete with them or whatever, but to be just somebody there that you can kind of do the exercise with. It's sort of like pushing each other, or gauging each other, and keeping up with the other person and whatever. In my case, being up here in Elk Rapids, up in the very northern end of the Michigan mitten, when I was bicycling with my wife and we would get out together, that was always a lot of fun. Now, I noticed that I was having some trouble, and she had knee surgery as well. We could not bicycle like we did when we were kids and go the distance and get the workout we wanted. And I'm not recommending this for anybody unless they want to look into it, but we purchased electric bicycles, e-bicycles, that are pedal assist. They're not scooters. They're not electric motorcycles. They are bicycles with electric motors. And this is allowing my wife and I a whole new breath of fresh air. And that I can tell you that I sleep really good. Somebody mentioned earlier, I think Rick was talking about his sleep, and somebody asked if it was deep sleep. I can tell you now, I know I'm getting deep sleep because I'm having dreams again, and I can remember those dreams. And from what I understand, that's a deep REM sleep. So having that exercise has made a huge difference, not only for my weight and helping keeping my cholesterol down, uh, but it's been very, very good for helping me to sleep, uh, and help to kind of shake off some of the fatigue that I'm having. So that's what I
Right.
wanted to share with you guys.
Very good. Jay, if you're in the villages, there's got to be hundreds of guys in a similar situation as you. There's probably a newspaper there that that has where you can find guys to walk with, or do things with, just to keep active. Because this is you're in a community there with people in their 60s, 70s, and 80s that there probably many of them facing the same situation, and you could probably find people to walk with, and forget about it, throw away the keys to the ATV and just walk.
You mean give up my golf cart?
Yeah, give it up for a while.
Two questions. First of all, is sitting on the bike detrimental if you have prostate cancer? Because I've heard
No,
some people.
no, it shouldn't. No, it should be fine.
Do you have any recommendations for a good seat?
Yeah, I got a special seat, and I can't tell you. I went online and looked for it, but I did get a special seat on both my stationary bike and my mountain bike. So I think that was recommended by one of the physicians.
Okay.
I have a seat with. As John, I have a seat with no middle in it.
Yeah, that's mine is too, John.
Same kind of thing, yeah.
Okay.
A
But
padded
you don't have to.
full seat.
I'm
No
sorry?
crotch seats.
But you don't have to worry about it spreading your prostate cancer.
Don't worry
What
about
I learned about bicycle seats is they actually call them saddles, and I had to try out a couple of different seats. I have a local bike shop here, and they let me actually try them out and change them out until I got one that felt good. But I know that after my biopsy, they told me no bicycling, and also after the high dose radiation, they said no bicycling for about 6 weeks. So, but after that, I was good to go.
So Jay,
Okay.
another thing you might talk to your doc about, again, this is not medical advice, but there are Xtandi does take a toll on people, probably more than some other second line. Earlier on we were discussing darolutamide. There are other second line antiandrogens, but I know that a lot of guys have some trouble with Xtandi. And you might talk to your doc whether it's worth trying another drug like darolutamide or apalutamide or something to see if it can take some of the intense fatigue away from you.
Okay, good idea. Yeah, I was keeping a log, and after the Degarelix injection, that's when all of the symptoms showed up. And then
Yeah,
I started,
it's a gut shot and it's very uncomfortable.
yes. Yeah, I do some Tai Chi daily, but I guess that's not aerobic enough to alleviate, um, the other symptoms.
Right, and you want to do some strength exercises too, not just aerobics.
Yeah.
Light
So
weights.
Jay, let me throw one other thing out on the exercise. I agree with what everybody said, but if you can find a younger group of guys to hang out with, boy, you'll find that they push. I hang out with, some 40 and 50-year-olds, and and I've told them I want to be pushed. I want to be, and they're all right. You want to be pushed? We'll push you. So, it's and doing something with somebody else is always better than trying to do it alone.
Yeah, usually my wife and I do a lot of stuff together. Um, so she's my the one who kind of pushes me, which is really great.
Let's make sure that Jack knows about the chat box. Up in the upper right of your screen, there's a thing that looks like two squares, one over the other, with jaggedy bottoms. And
Got
a
it.
lot of discussion is going on in that chat box all the while. There may
Thank you.
even be things directed at you particularly. So keep look on that whenever you want to, and you'll see various discussions going on.
Thank you.
Okay.
Thank you.
Len, welcome to the call. We're talking to, I don't know when you joined, but we're talking to Jay, and he lives down in the Villages, which you're familiar with. So, you have
Yeah,
a comment for him?
yeah, I've been on for a while. I just turned my camera on because my internet connection said it was unstable. So I'll see how long this lasts. But um, yeah, I do not live in the Villages. I want to go on the record right there. Never will. But anyway, Jay, uh, just looking at you, it seemed like your breathing was a little bit labored. Have you been, before you get into a rigorous exercise program, you should get cleared by your cardiologist and pulmonologist?
Okay. One of the side effects that I'm having recently is my head is filling up, and I feel like almost like a cold, and my ears are blocked, and that makes me dizzy. So I don't know if that's what you're seeing, but
Okay, I mean, that could
yeah.
be an Xtandi side effect. I don't know. But I mean, do you have a history of cardiovascular or pulmonary issues?
Mild emphysema.
Okay, so there you go. I would definitely uh, talk to your doctor, whether it's a cardiologist or pulmonologist, and maybe they can recommend someone to outline an exercise plan for you that's safe for you.
Okay.
Okay, that's it for me, Peter.
Okay, good point. pick up. Yeah, most of us, and Rick wanted us to do a show of hands, but probably almost all of us have found that we've got to stay active in some way to stay in this game. Otherwise, it just really knocks us out, kicks our butt somehow. And we just have to find some way that works for us to stay active. Whether that's in a gym or whether it's exercising with somebody in their 50s, whatever it is, you got to do it. That's any medical oncologist or a doctor who treats prostate cancer usually will tell you to do this kind of stuff to get active somehow, because it's one of the few things you have control over. That, your diet, are big ones, and some of your mental activities. Because some of these drugs can mess up your mind and brain too, with brain fog and so forth. And you want to exercise your mental abilities too as best you can. Find things you can do to keep your mind active, because these drugs can eat you up, and you don't want that to happen. Especially when you start, you get in your mid 70s, you got years to go, and so you can do something about it.
Good advice. Thank you.
Okay. Yeah, stay with us. Put your email in the chat window if you want, Jay. And how did you find out about the group?
I got an email from a local prostate cancer group who had all of the information about what meetings you have and where to go, and
Great.
that was dispensed to the local group, and that's kind of how I found out about a lot of stuff.
Great. Yeah, Len has spoken at conferences down there, right, Len, over the years?
Not at the villages, although I might be there actually next November, because Jan Mannerite's got another conference planned in the villages like she did last year.
Right. Okay. Several other people want to go. Tom Maloney, you had something you wanted to bring up.
Okay, thank you. I'm 5 years into this Gleason 9 with a bilateral orchiectomy. I've had 3 cycles of Pluvicto, and now I think I'm going to stop the Pluvicto, even though my onco, Misha Beltram, wants me to keep going. But I'm already getting dry mouth and dry eye from it. And I don't think it's worth it going past 3 cycles. I'm kind of disappointed with Pluvicto. It knocked out 99% of the cancer, but it is doing a number on dry mouth. And the other things I have a lot of sleeping. I can sleep now, and depression is starting to filter in there. So it's not a great life at Gleason 9. Any comments?
Yeah, a bunch of us probably have some comments. Who's done Pluvicto and either the full 6 or whatever? Anybody on here gone through this?
The Pluvicto protocol is 4 with 2 additional at the request of the treating physician, but 4 is the full shot.
No, it isn't. It's actually 6. That's how it was approved. We have a lot of respect for Dr. Beltran on this call. And she may be presenting it to you that way, Tom Maloney, but It was approved for 6 weeks apart, as I recall. That's the standard dose. Now,
It was written up in a journal of
okay,
New
I'm
England
going to refer
Medicine
you. I'm not going
in
to argue
September.
with you, Tom. Tom, I'm not going to argue with you. Well, I'll post the FDA. I'll post what the FDA approval was. Okay, this isn't about writing up
Okay.
in journals. The FDA approval was 6 doses, 6 weeks apart. That was the FDA
Okay.
approval. Can it be given differently? Sure. But that's how it was approved, and that was based on the Vision trial, and it was based on the trials in Australia. We've had many men who have done Pluvicto. Most of them have gone through the full 6, but not all of them. So all
Now,
I'm
what do you
saying
think
is,
about quitting early?
if it were me, I would say it's foolish. If it was me, I would go through the whole thing. Yes, every treatment has side effects. Every treatment has side effects, and we know that there are issues with dry mouth. But that's it's a pretty minimal downside for what it delivers to you. But if you want to get the most out of the treatment, I would say listen to your doctor and follow the protocol that was observed. Is there anybody on this call right now who has completed Pluvicto? Do we have anybody today? Jim B, how many have you done
guess not.
so far?
I've had 4 treatments and coming up to 5 and 6 here. I have the dry mouth and a little bit of the dry eye, that sort of thing, but that's nothing compared to keeping my PSA below 1, which I'm very happy to see. So
Right.
that's well worth the side effects. Side effects to me aren't that severe. So some abdominal discomfort and fatigue and the dry mouth, dry eye, and that sort of thing. But I've been faring pretty well and happy with the results so far.
Yeah.
Did you say you
Tom?
had 99? Did you say it was
Rick?
99? Removed 99% of your cancer?
It did.
I mean, that's a pretty astonishing result. I'd be doing the jig, I think.
Definitely do the jig.
Yeah.
Tom, what,
Well, it's
one of
99% gone. Why keep going? Sorry, go ahead.
one of our participants who's not on tonight, Dr. Bob Germankin from Philadelphia, he's a retired dentist, and he recently, because of my issues with dry mouth and talking to him, he put together a 4-page kind of cheat sheet paper dealing with dry mouth. And we can get you a copy of it. I know Rick probably has the updated one. I've got one of his first ones. I don't have the updated one, but maybe Rick can shoot it over to you if we have your email. But it's helpful because there's a number of products on the market that help with dry mouth, because I'm dealing with that myself right now, not from Pluvicto, but from another treatment. So it does happen.
I'm using Mouth Coat. I think that's a good product.
Yeah, there's also some biotine products, and there's a number of different products and tricks, and so his paper's worth it because it gives you some ideas of how to keep your mouth clean, because saliva has a lot to do with fighting tooth decay, and you want to make sure you're keeping your mouth clean.
What I don't hear on the thing is depression is a big part of this disease too, isn't it?
It sure is. It's a big one. John, you have a comment on that?
Yeah, depression is part of the disease, and it's also part of the treatment. Depression is one of the symptoms of androgen deprivation. It's a symptom of stress and anxiety, and it deserves to be properly treated. Exercise is good for depression, but if it's not sufficient, then it might be a good idea to go consult a psychiatrist.
And there's no shame in that. I mean, I've been at this 9 years as a Gleason 9. And early on, I think my first year, I realized I needed to get some help. And so I'm on a very low dose of an antidepressant. And I've been doing it for many years. It hasn't curtailed my spirit or hurt me in any way. But there's no shame in seeking help for that, because you don't want to go into a depressed state because you're not thinking clearly, and those around you are not going to be happy about you.
Agreed. Yep.
Okay, thank you very much.
Okay, Tom. Spencer.
Okay, I'm unmuted. Okay. I was diagnosed last October, and I am at a Gleason 10, and there's an extensive amount of tumors in the prostate and in the surrounding areas, and it happened rather quickly. And the way I noticed it was I lost the ability to urinate, and they tried to do a TERP operation on me a couple of weeks ago, and they were unable to do it because there were so many tumors involved that they just couldn't get into the prostate to take care of it. So I am walking around with a catheter. I did get a suprapubic catheter, which doesn't go through the urethra. It doesn't go through the penis. It goes above the, in the lower abdomen, and that's much more comfortable than the other one, than the Foley catheter that goes through the urethra. That was killing me. So I'm walking around with that. I'm on the anti-hormone therapy, abiraterone and Lupron, and I've been on that for, I guess it's close to 6 months now. I get my next Lupron shot in a couple of weeks, and they said that the only thing that's going to help the only possibility to help the prostate, so I can start urinating again, is that the treatment shrinks the tumors enough to open it up, or at least to give them enough room to operate. But so far it hasn't happened. So that's where I am.
Spencer, where do you live?
In Philadelphia, and outside the suburbs of Philadelphia. And the doctor's in Jefferson Medical.
Okay. So I was similar to you.
Mm-hmm.
I had urinary retention from the get-go, and that's what led me to find out I had prostate cancer.
Right.
And I went to my medical oncologist wanted me to do radiation, but the radiation docs would not talk to me because I was on a catheter for 7.5 months.
Mm.
I closed up the night of my biopsy. That was the last time I urinated for 7.5 months.
Wow.
I was on a Foley catheter, and then I was also on self-catheterization. But I knew I would have, for me, I had to do surgery. I knew, I couldn't get a definitive answer, but I knew that, but I got the impression that there was tumor in my prostate that was blocking my flow.
Right.
And even though I was on ADT, it wasn't shrinking enough. So my mission in life at that time, this is 8-9 years ago, was to find the best surgeon I could find, a world-class surgeon, which I found at UCSF, University of California, San Francisco. I live in Hawaii, and I knew I wasn't going to find one there.
Right.
So, and I trusted him. I came out of surgery able to urinate and fully continent.
Wow.
And I've been that way for the last 8 years. Of course, I made some sacrifices. I lost all sexual function, but that was the trade-off. No more catheters. I was able to urinate, and I'm able to hold my urine. So it was a successful operation. But you don't want to go to just anybody, any old surgeon. Just interview with the best. And you're in a good area. Philadelphia's area's got some good ones. DC area's got some great ones. New York's got some great ones. Just talk to people and
Well,
see
the
if it's
problem, yeah, the problem is I have talked to people about it, and they all say that I'm too old to have the surgery. They say
How
that
old are you?
I'm going to be 80 in a couple of weeks.
Yeah.
And they don't like doing the surgery on people over 70, and they really don't like doing it over 75.
Yeah, I was 66, so I was under the wire. Yeah, I feel for you.
Yeah.
Because it's a terrible boat to be in. Yeah.
Yeah.
Can I ask a question?
Sure.
I'm 80 and I don't have the urinary problems you're describing,
Right.
but I was really anxious to get my prostate removed, and 3 surgeons told me what you heard, and the final surgeon who said she doesn't like to operate on a guy my age is because the likelihood is I would be incontinent forever after that. I'd wear diapers for the rest of my life.
Yeah.
I don't know if that's true. I just don't know. But so I'm sorry what you're going through, but I just wanted to share that. I don't know. Does anybody else have pick up that same information?
I've heard that
Can
too.
happen.
Same
Incontinence
information.
can happen.
I was 73 and I knew that I wanted a prostatectomy. I went through this whole questionnaire by the American Cancer Society, I think, and I lobbied for it. And Dr. Correa finally said, "Yeah, we're going to do it. You're right. You're in good health. Yeah." Well, I don't totally have my continence back. Boy, one light pad a day, that's not bad.
Oh no, I'd be happy with that.
Yeah, I was specifically told that the body heals differently when you're that old, regardless of what kind of shape you're in.
That's true. Very true.
Okay.
Very true.
But they keep telling us everybody's different.
Well, yeah, everybody's different. I was 76 when I had a robotic assisted radical prostatectomy. And the minute they took the catheter out, I was continent and have been totally continent ever since. So
there you
again, and they had no reluctance to do the prostatectomy because of my age at 76.
Where did you have it done?
But again, I'm in good physical health otherwise. I don't have a lot of other problems.
And I think it's fair for them to tell you might be incontinent for the rest of your life, and then that's the data on which you have to make your decision.
Yeah, yeah. No, because I'm about to undergo proton therapy after taking Orgovic and Abby, and that's what the deal is. And once they do the proton therapy, I guess surgery's out.
Well,
Spencer, what kind of shape are you in?
I'm in very good physical. I'm very active. I've been active all my life. I work out 5-6 days a week, aerobic and light weights.
Okay, but I was talking to Spencer.
Yeah, I'm not quite that active. I have a personal trainer 3 times a week. I do an hour each 3 times a week, and I do some walking besides that. But I probably should be doing more. But physically, I'm not. I was fatigued at the beginning of the when I was diagnosed, and I was almost bedridden for a couple of weeks. But that seems to have abated. I'm fairly active. I think. I'm getting out. I'm walking. You know. Uh, I haven't gotten back on the golf course yet, but I intend to do that in the next couple of weeks. That'll be a big test for me if I can do that. But as far as the catheter is concerned, I was doing self catheters for a while, and even that blocked up. I can't even do the self catheter because I can't get through the tumors up into and get into the bladder. However, the suprapubic catheter is an amazing thing. They basically, I don't know if you've heard of this, but I hadn't before it was recommended to me. They put they basically punch a hole in your lower abdomen and put a catheter from there into the bladder. So there's really no pain like there was with the Foley catheter, and I'm walking around with that, and I'm surviving with it.
Right. I had one of those installed when I had my surgery, just in case that didn't work. But I never had to use it. But it was but they did it. They closed it afterwards. They closed it up. Yeah. That's I feel for you. It's a.
You think I should still continue look for more doctors that might do the prostatectomy?
If you can find, maybe a world-class doc at Memorial Sloan Kettering in New York, or somebody who.
The guy I'm using at Jefferson is supposed to be one of the world-class guy. So I don't know, but yeah, I could try Sloan Kettering, I guess.
I mean, there are some great, there are some good doctors around, but it's a tricky one. As Jack G was saying, a lot of doctors will not take the risk over 80 because at 80 years old, because we don't heal as well at that age, no matter what shape we think we're in. The body's been through a lot of living by 80 years.
Yeah.
And it's I don't know what to say. Anybody else have any comments?
Yeah, Peter, I wanted to know, Spencer, what was your initial PSA?
The initial PSA was 22.
And had you been following your PSA, tracking it
Yeah,
up to that?
yeah. I'm due for another one, but the last one I had was around 2.5.
No. I mean prior to your diagnosis.
Oh yeah. Well, prior to the diagnosis, I was getting it tested annually with my annual physical, and it was never above like 2, maybe 3 once, about as high as it ever got.
And then it just jumped to 22?
Yeah. I was, what happened, last summer, I started having trouble urinating. And I went to the urologist, and he said, he just said, you have an enlarged prostate. He didn't think it was cancer. And he was going to schedule me for a test, for a,
TERP.
The TERP. Yeah, one of the TERPs. Something about there's something with water that they do. Aquablation, I think it's called. And he was going to schedule me for that. And then he when he went in to do it, he couldn't do it because there was so much. The prostate was all misshapen and stuff. And so he did a biopsy at that time, and that came back positive, and it's Gleason 10, 5+5.
And did they test it for genetic mutations?
No, they didn't. But I did do the PET scan, the PSMA PET scan, and an MRI. and they found some involvement in the lymph nodes and a little bit in the iliac bone. So that's when they put me on the abiraterone and the what's it called, neutron.
So you do have at least one bone metastasis, is that right?
I think so. Yeah, yeah.
Did they put you on Xgeva?
No.
Talk to them about that. You probably should be. It's a bone strengthening agent. It's been shown to delay further progression of bone metastases.
Oh, really? Is it EXCHIVA?
No, Xgeva.
Xgeva.
Yeah, that's it.
Okay. This is.
Yeah, talk to them about that. Okay,
I definitely will. I'm seeing the oncologist on the 23rd, so that'll be that's when I get the next leuprolide injection, and they'll do all the testing prior to that, and we'll see how my PSA is and all that good stuff. But yeah, I will definitely talk to him about Xgeva.
Okay.
Yeah, I'm sorry you're going through this. I know
yeah, it came like a shock, and I thought at my age I was past all that. I didn't think people that as old as I did got prostate cancer.
Yeah, prostate cancer is a sneaky demon. It
sure is.
Gets you when you're young. It can get you when you're old.
The other thing which somebody just raised, and you should talk to your oncologist. You're seeing Dr. Tester? Is he?
Right.
I forget it. Is he a medical oncologist or is he a surgeon? I forget.
He's a medical oncologist. I'm also seeing Dr. Chanot, who is a surgeon.
Right. So I would insist with Dr. Tester that he does both germline testing just to see if you've got anything inherited, and also somatic testing.
I did the germline testing. I did the that color thing.
Yeah.
That came back negative.
Okay. Yeah. But definitely, I think you should ask him. Tell him you want a somatic test.
Okay.
Because it is now in CCN, and very, very often these docs just don't insist on it. I mean, it's just amazing, and it's required. I mean, I was listening to I know Len listened to the ODAC hearing on olaparib and abiraterone, and both the FDA and AstraZeneca were saying how infrequently the docs request testing. I can't. Len, can you remember the percentage of people that it was really low, wasn't it, of the people that get tested?
Yeah, I don't recall, Rick. Definitely less than 40, but I don't have an exact number.
Yeah, it was really low, and it's essential information.
When I first my first visit with Dr. Tester, he had talked about the somatic testing, but at that time he thought that the prostate cancer was just limited to the prostate, and then once they did the PSMA PET scan and the MRI and found out that it had spread past that, then he didn't think it was worthwhile to do the somatic testing. I don't know why, but so if they do the somatic testing, how would that change the treatment options?
Well, it may point out certain mutations that you have that would indicate drugs that can be used now, where you're a tough candidate for radiation, and
Right.
you're old for surgery, and there may be some other drugs that they can use instead of or in addition to the hormone and the abiraterone, the LHRH, the Lupron and the abiraterone. It's not likely, but it's possible.
Okay, I'll definitely talk to him about it.
And plus the fact that it gives you a baseline. You might need to do it again in 2 years. You can see if anything's changed. There are reasons to do it. That they would have to do it with you right now with a soft tissue biopsy, but that shouldn't be too difficult.
Well, actually, when they tried to do the TERP, they did a biopsy at the same time.
And how long ago was that?
A couple of weeks ago.
Okay,
Oh, no,
perfect. So
no. I just have they just recently, I think it was like May the 18th. They
perfect.
attempted the TERP. So
Perfect.
I have a biopsy as of.
Right. So they can send that off. Perfect.
Okay. Yeah. He may be doing that. I'll definitely find out for sure.
Yeah. Well, I'm sorry you're going to.
I have an appointment with him on the 23rd. Yeah.
Stay in touch with us. Let us know what he says when you meet with him.
Okay. I certainly will. I certainly will.
Do we have your email, Spencer?
Yes.
Yeah.
Okay.
Do you?
Yes.
Yeah.
Yes.
I'm getting your notifications. I guess you have it.
Okay. Okay. Julian.
Before you move on, there's a problem with this session, just like last week. Right now, active cameras shows us a maximum of 9 people instead of 25. I don't know if everybody else is having this, but this is the first time I've seen this. Okay, not everybody else.
I'm getting 25.
I'm not having that problem.
Not me.
Yeah.
Okay, good. I thought it was the session. I'll restart.
Okay. Thanks for your advice. I appreciate it very much.
Okay. Julian.
Yeah, so I went to go see my med-onc today, my 3-month visit, and now becomes a 4-month. I've been 0 PSA for almost 2 years now, and everything's looking good. She said you stayed on the protocol, through thick and thin. My PSA at one time, got up to almost 9. But the worst part of that was that I had a Gleason score of 4+5, courtesy of John Hopkins. So I'm thankful where I am and in talking to you guys. But my med-onc said, you got to stay with the protocol, even though it's rough. And she applauded me for exercising as often as I do.
Very good. And who's your med-onc, Julian?
Dr. Eleni Estasiou.
Good. Good for you.
He's my quarterback.
So
right.
So she's saying you can stay off the meds longer. You can continue your holiday. Is that right, Julian?
I haven't been on the meds since November of last year.
Okay, no wonder you love her. No wonder you love her. You know?
She gave me a hug too today. I said, "Oh my God."
You should have told her she owes me a telephone call. You should have told her you owe Rick a telephone call. She would have laughed. No, she's we like her. Yes. Yeah. I won't say any more.
Okay. So I'm gonna make an executive decision here and spend a few minutes with myself before we close up shop, and maybe if we have some time, maybe Len can have some comments on statins. We had an early discussion while you were still in traffic. Is that someone from the MS group on there? Guess not. Okay, so some of you know this, but I'm on an immunotherapy protocol, a drug called Keytruda, and I started it here in Minneapolis last August, and I've had some ups and downs with it, but right now I'm having some ups and downs with it as well. So I just went in to see Dr. Antanarakis here at the University of Minnesota yesterday, and I had my 11th infusion, 11, count them. And my top question for him was, where are we going with this? So amazingly, I qualified for this because I have a mismatch repair gene, Lynch syndrome, MSH6 gene mutation, and I've got what's called MSI high, microsatellite instability high. Don't ask me to explain that to you. I can't do it. But it makes me qualify for Keytruda, which is usually not a standard treatment for prostate cancer. It is for a number of other cancers, including colorectal cancer, with this kind of mutation and some other things. But I qualified for it, and my PSA has been dropping and dropping and dropping. Every 3 weeks it drops. So it is now down to 0.17, which it hasn't been for a year and a half. So I'm a happy camper. So I obviously asked Dr. Antanarakis where we're going with this, and he came up with a plan and said, well, let's try to get to number 13. That's my lucky number. So that means after yesterday, 2 more, 3. So 6 weeks from now, maybe I will take a holiday and be on nothing. This is the only drug I'm on is this immunotherapy Keytruda. I'm not on androgen deprivation anymore. I'm not on darolutamide, nothing else. This is it. And the other surprise that came to me yesterday, I have to do blood work every 3 weeks for this, is that my testosterone, for the first time in a year and a half, broke the 100 mark. It's been hovering around 60 or 70 for months and months and months and months. And it, for the second time in 2 years, it broke the 100 mark. I mean, that's not bragging rights, but it's something. I mean, I'll take it. So who knows where this is going? Is this going toward remission? I don't know. I'm an odd duck. I'm different than most guys, but I've been through it all. I've been through 6 months of chemo, double dose. I've been, with carboplatin as well as docetaxel. I've been through 2 kinds of radiation, proton as well as IMRT, photon. I've been through surgery. I've been through all kinds of ADT and this and that. But this one seems to be showing some promise and some results. And it's got some downsides. The first couple of weeks afterwards, including today, some intestinal stuff. There's diarrhea alternating with constipation, going back and forth. And as I wrote in one of my reminder notices recently, I kind of have to know where the bathrooms are at all times, but it doesn't stop me from going out and being active. And my appetite's low, and I'm losing a little bit of weight, but and I've got the Pluvicto dry mouth, even though I've never done Pluvicto. I don't have the dry eye, but I've certainly got the dry mouth, and sometimes I can hardly speak. So there's some downsides to this stuff, because when you start messing with the immune system, you don't know what you're playing with. But I'm willing to go with it. So if any of you have any questions, that's where I am with it. It's not a cheap therapy. I mean, my Medicare and my secondary pay for it, but they actually pay. It's not billed. It's billed at $30,000, but they actually pay $10,000 every 3 weeks, and this is number 11 that I've done. So
how do you spell that drug?
Keytruda. You'll see it advertised on TV all the time. It's a Merck drug.
One more time.
Keytruda.
Peter, when did your
Thank you.
journey begin? When did your journey begin?
Hold on a second,
All right.
Dr. Jack.
Oh, Keytruda.
So, John Bab, this is
Yeah,
not a drug that is suitable for everybody.
I
So
understand that.
there's no, the first thing you must do to know if you're eligible is you must do this somatic testing that we've been talking about. So have
Right.
you had your somatic testing done yet?
Well, I just spoke with you guys probably a month ago, and I have an appointment with my general physician's urologist, who will point me towards to a GU medical oncologist. I had my PSMA PET scan just the other day, and I was going to put it up on where you guys could see it and interpret it, but I've not seen my urologist yet. So to tell you, the answer is no. I'm working that direction. In 3 weeks, I have an appointment with this new urologist who my GP says will direct me to a GU. Go ahead.
Well, you don't need the urologist to direct you to the GU, John. As we said to you, Dr. Efstathiou or Dr. Korn, it's possible. I mean, by
in
all
Oklahoma?
means, wait, but time is of the essence, and the sooner you get in, and you have to get this somatic testing done, and that will that will give you a guideline. I mean, to talk to your urologist about pembrolizumab, he's going to roll his eyes.
Okay,
So
I do not know here in Oklahoma City or a GU medical oncologist to go to, and
yes, but
that
there isn't one. We talked about this when we did the intake with you, and we recommended that you see Dr. Efstathiou in Houston or Dr. Korn in Houston. That was the discussion we had with you 2 or 3 weeks ago when you
yes,
came in.
yes.
So what we're saying is you don't need a urologist to direct you there. You can just pick up the phone and say, I'd like to make an appointment.
Okay, I was under the impression there might be a GU medical oncologist here in Oklahoma City, either with the VA, who I don't let them
No,
handle my
let,
cancer.
let, let, let me, none that we know of. None that we know of. And Mike Yancey, I don't think he's on. He's looked extensively and finished up going to people outside. And we don't know of a good GU medical oncologist in Oklahoma. But there may be one that we don't know, but we don't think so. And so you're probably going to have to go to Dallas or Houston. And
Yeah.
we would suggest Houston because we think we know them. The ones in Dallas that we know, we have less confidence in. But that's what we're suggesting.
Okay. I
Okay.
do have those notes. I've just been working towards it.
Okay. And sorry, Dr. Jack, you had something you wanted to ask.
Yeah, I'd just like to ask Peter a question because I'm not aware of your history, Peter, and just I'd like to know how you've evolved over the years to have so many mutations, and so you're a candidate for Keytruda. How far back does your disease go? I haven't been around in the group long enough to know, but you've been here forever.
9 years. I was like Spencer. I was driven to a urologist because I had urinary retention, and
And Your initial somatic testing showed?
My initial genetic testing, germline testing, showed a germline mutation with Lynch syndrome, the MSH. So I knew right away, but I didn't. But my when I did somatic testing initially, my MSI was stable. However, the second time I had it, I was able to do another somatic test with new tissue because of because my cancer keeps coming back, and so I knew I had to keep doing stuff, and the second somatic test showed MSI high, and that's when I knew I was a candidate for Keytruda. But we ended up doing chemo first.
So the Lynch to begin with, the MSI as time went on with a new piece of tissue. Anything else or any other mutations?
Yeah, I've got a somatic BRCA mutation as well.
That came over time or initially?
Pretty close to the beginning, but they weren't really, it took a little while for, early on for these tests to show up. But it did show a somatic mutation BRCA2, but it can lead you astray. I mean, when I did my chemo, the thought was, well, maybe it was the BRCA2 that was driving this thing. You never know what's driving it, but now it seems obvious that it's the Lynch syndrome that's driving it.
How many of people are in the literature known to be treated with Keytruda with prostate metastatic disease?
Very few. It's very few. Dr. Antonarakis, when he was at Hopkins, he said he probably had half a dozen or something like that. But
he did.
Yeah, my local doctor in Maui has never seen anybody like me, and Dr. Schultz in California has one other guy who essentially went into full remission. So
wow.
I'm hopeful. Yeah.
Well, good luck. That's terrific. Good to hear. Thank you.
Okay, well, there's very few of us left.
Excuse me, Peter.
Yeah.
Could I have a second here?
Sure.
John Babb, I understand that you are a veteran. I heard the VA.
Yeah.
You should. The thing is, I think that you should sign up for our veterans group. Okay, ANCAN, has a veterans group that meets on the 4th Thursday of the month. I believe you will find it very enlightening.
He's signed up to get a reminder already.
Oh, he is? Oh, good. I hope to see you there, sir.
4th Thursday of the month.
Yes, sir.
Okay.
Okay, guys. There's another group coming in. Unless anybody else has something else. David, do you have something else you want to say?
No, just great job, Peter. Thank you.
Okay, thank you. Okay, guys. Good night. Thanks very much for everybody's participation.
Hold on. I wanted to check in with Ken.
He just left. Oh, sorry.
Yeah.
And he didn't speak up during the Pluvicto conversation.
Yeah, we have to draw him in, I think. Okay. All right, guys.
Good night.
Good night. Thank you.
All right, thank you.